This is Call the Psychiatrist, the show where psychiatrists answer your questions. I'm Dr. David Handley.
And I'm Dr. Abby Snavely.
On today's episode, we answer listeners' questions about the use of psychedelic drugs in psychiatry.
Say you like me, you better count the ways. Side to side.
All right, we're doing psychedelics today. Are you pumped for this?
We're doing them.
We're talking about them.
You gotta clarify so I can figure out exactly how pumped I'm going to be.
Right. Well,
sorry.
No.
No.
It'll be obvious I'm still quite neurotic.
We're discussing.
So we're not doing it. Yeah, we're discussing. Sorry.
Sorry, Dr. Dave. Okay. Anyway, continue.
Yeah. So I found getting ready for this episode to be pretty interesting, though. How about you?
Oh, absolutely. So much reading and podcasts and videos and documentaries. I mean, as we will discuss, the amount of information about this is kind of endless.
Yeah, I love these kind of topics. I was thinking it brings in so many different disciplines. There's neuroscience, politics, psychiatry, philosophy, history, religion, spirituality. I mean, there are so many rabbit holes to go down. Oh,
it's
and then
the best one.
Don't forget, we start talking about the nature of consciousness, the source of the ego. I mean, it gets pretty wild.
I mean, those things I already knew, but yeah.
Well, but I'm just saying, as you inquiry into them, you're already a guru. I didn't know.
I know. Yeah. I mean, there was parts of this that were novel, that were novel information, but some parts.
Well, and maybe just to point out, it's really hard to stay current on this because the research is coming out so much. Like it's accelerating every month. There's more. The popular press is constantly publishing things. People are really jived about it. Just last week, I wasn't even looking for articles, but Rolling Stone had an article. Harper's Bazaar did an article on mushrooming mommies. The New York Times keeps writing articles every time a new paper comes out. So it's hard to keep up to date. And I'm sure by the time we release this, we'll already be behind the curve again.
No, you're right. I mean, I was on vacation and I opened a New Yorker because I am, in fact, a psychiatrist. And in there was
standard reading
article,
material.
Right, obviously. But I was on vacation and there was a whole article about this self-appointed guru of psychedelics. It's everywhere.
There is this issue of over-promising and maybe under-delivering, but we can get into that. I mean, at one point, I was looking at pictures of ancient cave paintings, and then I think I was reading a neuroscience article on, pigs on psilocybin. So, it's broad, and I love it. So, I think the question will help us narrow it down a little bit. So, but first of all, thanks to Emily, because she was a person who suggested the topic. Also, thanks to Amber. She wrote in a question about ketamine, and we're going to save ketamine, I think, for its own episode. Our actual question that we're going to use today to help frame the beginning comes from George R.
I was wondering about how you both feel about psychedelics and psychiatry. I understand that many doctors believe they are the future and can vastly shorten therapy. Do you intend to move your practice into this area? What kind of patients would be the best candidates? I'm curious and kind of excited about the possibility.
Why don't we jump right into his questions, and then we're going to go back in the backfill information, talk a little bit about the neuroscience, the effects of the drugs, and definitely some history. This is a topic where history is important because the politics of this really trump science in most every turn. So I think that'll be interesting.
And I think provide important lessons for this wave or this round, right?
Yeah. I mean, the researchers doing this don't want it to go sideways the way it did in the 60s.
So listen, people, it's not just like a self-indulgent Dave history lesson.
Well, I appreciate you defending me on that.
I really am. There was going to be something more pithy there, but this history lesson's for everyone, but you're going to have to stay tuned. So where should we start with George? Yeah.
I think for George's question, well, for everybody, let's narrow down because there's a number of different psychedelics. So let's narrow down what we're talking about. I think we need to focus on psilocybin. That's the psychoactive compound in the so-called magic mushrooms. And then MDMA, that's a 3,4-methylene methamphetamine. More commonly known by
medical school.
Well, I wanted to just say it the first time. And then in the 80s at the club, it got called ecstasy. So we can refer to it as ecstasy as well, or MDMA. So the reason to focus on these, though, is so in 2017, the U.S. Food and Drug Administration designated those two, the psilocybin and the MDMA, as breakthrough therapies for treatment-resistant depression in the case of the psilocybin, and then PTSD in the case for MDMA. And so that designation was meant to accelerate the process of research, and it's certainly done that. These drugs are now in phase 3 trials. And phase 3 is really that last step before applications are submitted to the FDA for possible approval, or in this case, being reclassified as drugs that have medicinal purposes or that could be used clinically. So I think we're on the dawn of it. I think in terms of the question, are they the future? I think part of that is actually, are they going to change things? But before we get into that, I think they are coming. And maybe just to kind of jump to the real conclusion here, the current research is very promising, but not yet enough, I think, to get approval. However, I wouldn't be surprised if within a year these are submitted to the FDA and they will ultimately be approved, I believe, if I'm trying to foretell the future.
I mean, yeah, I think it's the future. I think the future is now. I think, as we'll get into, people are obviously already using these things, right? I mean, the mushroom mommies that you read about, are not getting prescribed these compounds, right? Like, it's happening, and that's complicated.
I think in Oregon, they've already decided that starting in 2023, they will be available in Oregon for therapeutic purpose. I mean, they're completely bypassing the normal drug development process, which is fascinating.
And they're decriminalized in Denver.
Mm-hmm. And in Oregon, I believe, right?
Yeah.
Which is pretty fascinating if you think about an actual medication. Like, can you imagine state legislatures or the citizens of a state demanding that a cancer drug be released for clinical use before it's been approved by the FDA? I mean, it's pretty wild.
And just deciding when you need it. I mean,
yeah,
it's
a really
wild.
uncomfortable boundary, I think, between the typical way science works and these particular drugs, which are, as you said earlier, I mean, these are already have been used and people have really strong opinions about them. And I think you have to.
Well, people are using them for partying, as we've pointed out, as well as therapeutic practices. Some people would say religious practices. There's certainly religious traditions that have used them. But people are using them for all types of issues already. And so as a clinician, we'd like to be more specific. But I wonder if the cat's already out of the bag in terms of, or whatever it is, Pandora's box is open, and whatever mixed metaphor you want, that it's going to be hard to define these medications or these compounds in a specific medically defined way.
Yeah, I think the cat is out of Pandora's box.
That's right. Okay, thank you. Yeah, I didn't know how to mix
That's the mixed metaphor you were
something
going
like
for.
that. Right. And then you got to herd the cats, and there's just so many problems. And you don't even know where you started. So.
Well, I think it's important to acknowledge your bias, meaning that, if you are really excited about this, you're going to downplay the limitations of the research. And if you're a hardcore skeptic, you're going to downplay the positive results. And I think just owning that is okay. The research, there are a lot of limitations, just like there's limitations in many kinds of research. Psychotherapy research, there's a lot of limitations. And so, again, I think just being more wide-eyed about it is the best direction forward, rather than getting so caught up with this being a promise of a revolution that will change every single person's life. But clearly the people funding this, that started funding the Renaissance, if you will, like the studies that started up again in the mid and then late 90s, they are very much interested in this being used for people without a diagnosed condition, because the belief,
just the human condition, that's the one.
Right.
That's right. The
one. Because in the same way that just like in the 60s, people, again, the proposal was that this would be something that would benefit all humankind. I mean, it really got grandiose because once you've been through that experience, then we can talk more about, I guess, what the experience is like for people.
I mean, do you think you're coming in with a bias? I think that bias issue is particularly interesting.
So I do. My bias is that I really want something to work. I want something new to be able to offer to patients for them to get better. We've been in a pretty long dry spell, a couple of decades, I would say.
Of nothing really new, right? Like nothing truly novel in terms of mechanism of action for a lot of things, but I mean, including depression.
Well, I came of age when the new generation of antipsychotics were being marketed, and those have benefit, but certainly there's always a lot of hype that can lead to disappointment
And the most measurable benefit to the shareholders.
right. It made somebody a lot of money.
Oh, for sure.
Well, and then more recently, we've had TMS, transcranial magnetic stimulation. We've had ketamine. But yeah, nothing's quite as transformative as I think we would all like. So yeah, my bias is that, I really want it to work. And the safety data is reassuring, especially if you're using these in controlled environments. So I think if something is relatively safe and it can offer benefit, then I'm really excited to see what happens. But then there's the skeptical side of me that I also know how we do things when the market gets into play. And it's going to be offered in many, many settings that maybe aren't ideal by many people who are interested in making as much money as they can. And so
but how do you make money if it's a once in a lifetime or once a year sort of treatment? Right.
There's a lot of humans to get in the office, and
okay, fair enough. Yeah.
And that actually brings up one of the limitations of the study is there's not a lot of long-term data.
A lot of studies in psychiatry and otherwise don't have long-term data, right? I mean, part of it is maybe you don't want to ask the question, but it's also very expensive. People are lost to follow up. There's all these confounding factors, I would say, in particular, when you're looking at mental health or subjective reports of symptom improvement, things like that. Like it's truly hard to study anyway. It doesn't mean it's not a real limitation. I just don't know that there's like a perfect solution to it, even with $1 gazillion.
Yeah, no, I agree. And that's the thing. It's going to happen. I am excited about if it helps people. I do think there will be people that are harmed.
I mean, in terms of biases, I am torn, right? As a clinician, I think, as you're saying, I want something that helps people and, provides another tool in the toolbox. I would like the science to be more rigorous. And then as a citizen or something, I would like society to have some handle on this, or I don't know. I mean, I think I'm conflicted. And maybe we can talk about, our experiences with patients, or I guess with what our patients have told us.
Yeah. My interest actually goes back quite a ways. I remember, I guess it was like early aughts when they had replicated some of the studies with terminally ill patients with cancer, alleviating some of the anxiety of death, and having, some of the most profound experiences I've had as a psychiatrist has been working with palliative care and patients on hospice.
Yeah.
And the idea of alleviating suffering in this way, I mean, that's really exciting for me. And it's, I imagine that suffering can be alleviated in many other ways, like with more traditional interventions, but time is of the essence, and
Indeed.
This appears to have a pretty radical impact. Those patients talk about that it's one of the, top 5 most moving things in their lives, up there with the birth of a child, their marriage, all that kind of stuff. And I don't know if you can offer that to somebody, and again, the risks are seemingly pretty low, I can get behind that for sure. I feel like you and I are in this generation where our teachers would have lived through the first wave, and many of the students we teach are living it in the second wave. And we were sort of caught in the middle. And I remember when those studies around the terminally ill people were available, and I asked some of my professors, right. And it was not to be spoken of. The history was that they had no comment. And, I don't know if they were in those groups tripping with their patients in the 60s.
Right.
But it was as if I was wanting to, or I was suggesting, that we should start bloodletting again to treat something. It was shut down.
Yeah, I had an attending say, basically, you don't want to get into this. You don't want to be fringe. You don't want to be seen as kind of like on the extreme ends of the spectrum. Like, to be a respectable psychiatrist, and maybe for the respectability of our profession, we need to stay within the bounds.
So there's the terminally ill patients. There's really good outcomes with smoking cessation, alcohol use, PTSD, OCD, depression. I think there's ongoing trials where eating disorders. Again, is it the panacea? I don't know, but it sounds like this may be very useful. And so it is okay to be excited about those things.
Right. No, I think it is. So maybe reading between the lines of what you're saying and what I'm thinking, if it seems to be safe enough and there are established parameters for it, would I move this into my practice? Absolutely.
Yeah, I plan on doing it too. I mean, I want to get some additional training. I wouldn't mind getting that done in the next year. I don't know that we'll get into some of the study design, but I guess just briefly, when these are used in a therapeutic setting, there's a couple of sessions to establish rapport and to set some intention. There's a lengthy session, 6 hours, at least in the case of the psilocybin. And then there's these follow-up integrative sessions to try to, come to some mutual understanding of what happened. But I can imagine this being a tool within the course of more typical treatment. Like I have a couple of patients now, I would, to be honest, I would love to offer this. If the current research continues to be replicated, it continues to down this trajectory, I think it could be really useful.
Yeah, absolutely. And maybe that is my bias too, but I can only imagine that the experience would be richer with someone who knew you well, right? I mean, I understand how researchers do it and these research clinicians, if they can show a good benefit with these 6 sessions or whatever, imagine how much richer that could be with a more established relationship.
Yeah. And I think in George's question, I think he mentioned accelerating the treatment. And I can see how that would happen. I think it would deepen and accelerate. I think, again, I'm pretty open to it. I don't think I'm really high on the openness scale in general, but I think in this regard, I'm pretty open to this.
Yeah, I mean, there was that, I guess there's a book, but an article in the New York Times about Thomas Insel and the way that all of this focus on biochemistry and brain science has led to new discoveries, et cetera, but hasn't really improved the lives of patients. And so it's not tit for tat, but I'm happy to balance the scale in terms of something that's actually helpful.
Yeah, there's so many journals that I stopped reading because it was nothing but brain image scans and genetics research. I mean, none of it was translational to actual patient care. And it might be. I mean, again, it adds to the knowledge base.
That's important.
Yeah, I mean, it may pay off, but I guess I've spent most of my
practice.
I've spent most of my career waiting for something to happen, waiting for something that might be more useful. And so,
I mean, I get a little queasy when they're talking about shaking up the snow globe, right? I mean, they'll say, oh, there's a part of it that's just the experience that's ineffable. You can't put it into words, but then sometimes the words end up being either cheesy or really mystical in a way that doesn't feel very scientific. But that's about me being comfortable with, I don't know, the dichotomy here.
Well, I don't know if it's just you. I think there's a lot of tension between science as an institution with a lot of the mysticism that comes with this practice using psychedelics. Right. There's the shamanism of the whole thing, and that can feel uncomfortable. But, honestly, a lot of what we do in medicine has a hint of shamanism. I mean, there's a performative aspect. There's about setting intentions and expectations that greatly helps the patient. I mean, even in surgical outcomes. I mean, it's not just...
It doesn't mean it's not real.
Of course, just like a placebo response is not... It's still a response. Yeah. I mean, that's great. You got a response and they actually took very little risk, although, even placebos have lots of side effects and things too.
Yeah, as it turns out. But yeah, if people get better, I don't necessarily care how they get there. But then it's it's a treatment that also mimics the state that master meditators can get into, or people have had ecstatic religious experiences.
Yeah, well, and I don't know if we came across as negative when we were saying, well, everybody's going to want to use this for everything. I mean, honestly, and back to your thing about someone who's a very experienced person in meditation. So I just want to highlight that a little bit. What you're talking about is a person who's in a functional MRI, their brain activity when they're meditating is like a person who is on psychedelics. And to be honest, that sounds pretty nice. I wouldn't mind shutting my, the riot going on in my head. If I could shut myself up for a few hours, I get it. I can see there's going to be a massive appeal. And I'm not even going to
judge the shortcut to get there.
Well, I'm curious though, because you're right. It is a shortcut because perhaps if I spent tens of thousands of hours in meditation, I could have an experience that is similar in terms of a
Literally.
different state of consciousness.
Right.
But I don't know. I'm really going to be interested to see if this jumpstarts a meditation practice. Like if you've had the experience, would you be more able to get into that other state of consciousness more often, or would those states last a bit longer? I don't know.
I mean, Sam Harris, who is, amongst other things, very into both meditation and psychedelics, felt like it was pretty complimentary that, his meditation skills were very useful in the middle of a psychedelic trip.
Mm-hmm. The people doing this research has led me to think that the experience in a therapeutic setting is presumably different than in other settings in terms of intention and things. In other words,
sure,
these drugs are available. I'm guessing, though, when you go and work with a therapist, the outcome might be different than if you're just doing it at a Grateful Dead concert.
And they do talk a lot about set and setting, which is both of those things, right?
Yeah.
I mean,
absolutely.
your mindset, your intention, where you're at in your life, right? I mean, someone coming in because of their suffering, coming in for help because of their suffering is obviously just in a very different spot, just mentally than someone who is trying to party.
Yeah. Well, let's see, moving through George's question a bit further,
Yeah.
He asked about patients who are the best candidates. So the conservative answer here, if we're following along with how things are supposed to go, is that, well, all we know are the patients who are in those studies. But immediately that shows some of the flaws in the studies because there's quite a lack of diversity in those participants demographically and psychiatrically. When you're doing a study, you have to eliminate as many variables as possible because you're trying to isolate the intervention. So, for example, if you have a history of alcoholism and you're depressed, well, that's creating too much noise, and so you'd likely be eliminated. But, a lot of studies have drawbacks like this. But one of the issues with the current research is a lack of generalizability. And so to know who are the best candidates, the people that are excluded in the studies, which I kind of think is a direction we'll go, are people with a history of psychosis, maybe even with a family history of psychosis.
Yeah, I saw that in a lot of the studies.
Yeah, and I think because you're taking the most conservative approach because you don't want to cause harm. In other words, in inducing psychosis that's persistent, uncovering a psychotic disorder. So I imagine that those would remain. And maybe a different part of your question is, well, who would benefit the most?
Right. But before you go there, I mean, I think I get why, from a research perspective, that's helpful. So if someone has this psychedelic experience, which probably by all external accounts would look psychotic, and then some period of time later, that person has a psychotic episode while not using the drug, then you could blame it on the drug, or it could be blamed on that person's schizophrenia or some other illness. And so I think it gets confusing and confounding. I mean, I think I also understand, like you said, not wanting to unmask something, or which happens with marijuana and psychosis, things like that. But I also would want to be open to this helping people. I mean, severe mental illness obviously is debilitating for people, or can be. And so if there was a way to study it and know it was safe, and it gave somebody with schizophrenia or a bipolar disorder with psychosis relief, I wouldn't want to keep that from them. And anecdotally, people with these illnesses have reported really good experiences on these psychedelics. And I think people with bipolar disorder would say it's really helpful when you're depressed, not so helpful when you're manic. That's more dangerous. To me, that makes sense. Or if we go back to that whole premise that this is an intervention that's effective for such a wide variety of diagnoses, people have comorbidities. So if someone has bipolar disorder, but they're also an alcoholic and also have PTSD, then is it worth the risk if it makes those other two things better? Especially if it's kind of an unproven risk, because we can say theoretically we think it's a risk, but until they study it, we don't actually know that it's a problem either.
Yeah, I mean, we have a lot of scientific papers giving these drugs to people with psychosis back from the 50s and the 60s. So it's not as if it hasn't been done.
But the standards have changed.
Well, the standards have changed, but also that's not the research that's going to be included in an FDA approval. So I would...
Sure.
And I don't know. I don't work for
I'm
the
just
FDA.
looking farther down the road.
I know.
I don't want to...
When these come out, it's going to be an exclusion criteria. Like they're not I mean, well, it'll be an exclusion criteria and people will do it anyway, right? I mean, that's the reality.
This is right. And then people are going to find out. And the people who do it anyway. So if the doctors are following the protocols and the exclusion criteria and doing what they're supposed to do, carefully selecting their patients, I think that's great. But then is someone who's at a higher risk going to go get something illicit and be more vulnerable to that? Probably.
They don't even have to get it illicitly. They will just go down the street to somebody who's less ethical, because that's what goes on now. I mean, you can find, if you've got the money, you'll find somebody to do it. So it's not there's no guardrails in the marketplace.
Yeah, and this is a problem.
Yeah, that's a problem.
Okay, continue.
Okay, I hope that answers your question, George. If anybody's been following along in this podcast, you'll have noticed the last several episodes we've been trying to keep it a little bit shorter. I think this topic, though, is really interesting. So I think, like I say, I hope that we've covered it for you, George. We're going to keep going and try to fill in a little bit more of the history, a little bit more of the chemistry around it. So I guess this will be part 2.
Yeah, it's not going to be short today, but it's going to be good.
I wouldn't set that bar too high.
Yeah. Okay, we'll see.
All right, so a quick acknowledgement that psychedelics have been used by humans for millennia. I mean, some archaeologists think maybe as much as 7,000 years ago. Presumably, they're used for divination, as a sacrament, maybe as part of a healing ritual. In Central and South America, these chemicals were staunched following the Spanish conquest because the practice was thought to challenge God in the Roman Catholic Church. In fact, the mushrooms in the rituals were referred to as the flesh of the gods, so I imagine that was awkward. So the first synthetic psychedelic, to get attention, that is, was LSD, which was synthesized by Albert Hoffman in 1938 at Sandoz Pharmaceuticals in Switzerland. At the time, no one was sure what it did, and so it wasn't until 1943 that Hoffman decided to take a closer look and somehow accidentally ingested it. It's a little unclear. He may have gotten it on his hand, into his eye. Yeah, he wrote...
Sometimes you just spill on yourself when you're cooking and you just lick it off absentmindedly. It might happen in the lab.
He wrote about a lot of his experience. His book is LSD, My Problem Child. And he wrote about this, but of course, in the retelling, it's all this, it's very... he may have been guided by some greater force, right?
It's prophetic or something.
It is.
Yeah.
It's just, chemists are so good at not putting things in their eyes, especially unknown, potentially dangerous chemicals. So I don't know. Yeah. He had the first hallucinogenic experience on LSD. And I know a quip I've read several times is the first trip that there was no expectations for. He didn't go into it, but with some expectation of what might happen. So in 1947, the pharmaceutical companies still didn't really know what to do with this. And so they just started sending it out to any lab or any psychiatrist that wanted to study it. And to say it was a success would be an understatement. I mean, people thought this was a wonder drug and it was going to revolutionize psychiatry. People started studying it in the context of alcoholism, depression, anxiety, OCD. Abby, you mentioned that our standards are a little bit different in terms of scientific research.
I think so.
Yeah. I mean, for example, the psychiatrists were often also on LSD during the experiments.
At the same time. Same time. I think there's a Mad Men episode about this.
Oh, really?
Yeah. Roger Sterling takes it, I think in maybe a cocktail party at a psychiatrist. There's all kinds of standards that are different. Okay. But yeah, absolutely. Anyway.
Okay. Yeah. I mean, imagine.
Clip.
Yeah. The notes are probably pretty interesting to read. So the patent on the drug expired in 1963, which coincided, certainly it was already in the community, but I think when the patent expired and it was getting produced by a lot of different people, and let's just say it was being used in a lot of non-clinical settings at this point. And, this was a factor in the counterculture movement. There was a fear that people would be less likely to be conscripted into military service, less likely to, join a corporation. And so a moral panic ensues at this point. The flames get fanned by Timothy Leary. He's a psychologist hired at Harvard in 1960. And he really becomes a lightning rod for the establishment. He's got the famous speech that you've all heard, that clip from the turn on, tune in, drop out. And then later, Richard Nixon describes him as public enemy number one. And, I have to say, I am flattening this so much. And all of these little elements are so interesting. Timothy Leary
the Harvard Medical School professor being public enemy number one.
Oh,
I
Timothy
mean,
Leary's life is ridiculous. I mean, after
yeah.
he gets booted from Harvard, there's that Beatles song "Come Together," which that was originally going to be part of his campaign. His campaign slogan was "Come Together," but then he gets arrested for marijuana possession. So anyway,
Yeah, I
I'm,
know.
I'm
Right.
not
We
going
could
to
go
take these.
forever.
I'm not going to take these tangents. I wasn't going to, but I want to. So in 1965, so the U.S. Congress cracks down on the availability for LSD for research, which essentially puts an end to further study, with a few exceptions. It kind of goes into the early 70s. But up until that point, 1965, there were at least 1,000 scientific papers on the use of psychedelics for various maladies, psychiatric illnesses. And that includes 40,000 participants. So there was a body of evidence. It was what it was. That was basically shut down because of politics. 1970, Nixon passes the Controlled Substance Act. And so drugs like LSD and psilocybin, all the psychedelics, and marijuana get classified as a Schedule 1, which means there's no medical use, they're not safe, and there's a high potential for abuse. And then 1971 is the beginning of the war on drugs. But, it reminded me a little bit of the ECT story that I think I mentioned in episode 2 about scientific progress is essentially stopped by politics.
Well, I mean, or you could also just, I don't know, look at the last couple years and notice that if you pit science against politics, politics is going to win.
Every time.
Right? I mean, every time. So.
All right, that's LSD's story, which, by the way, there's still research now with LSD and DMT. They're earlier in the process. They're not into the phase 3, but again, we're going to get more information coming up. So let's see now if I can just weave in psilocybin story quickly, because it's also really fascinating. We left off with the Spanish conquest, so
obviously,
so the use now goes underground for about 400 years. Not to say that it goes away; it's just that white people in the United States don't know about it. And then a vice president at J.P. Morgan Bank, who's also an amateur mycologist, R. Gordon Wasson, ends up going on an expedition to Mexico in search of these psychoactive mushrooms. The story is apparently funded by Life magazine, who publishes his and his wife's account in an article called "Seeking the Magic Mushroom" that came out in 1957. And in fact, that's the first use, as far as we know, of magic mushrooms. So that's all Life. That's Life magazine.
I mean, these were some real straight-laced people in the mainstream doing it.
Yeah. Just like Bill, what's his name, from Alcoholics Anonymous. He was a huge proponent of bringing in psychedelics into the treatment for that. And he was quieted by the people that had taken over by them. But listen, so presumably this was funded by Life magazine. However, starting in 1953, the CIA had been conducting experiments with LSD as a possible weapon of war or for mind control, because when under the influence of these drugs, you're highly suggestible. So that program is called MK Ultra. And a lot of the records from that program were destroyed by a later CIA director. But one of the intact documents was that they had actually funded the Wasson expedition. Wasson didn't know it at the time, because they were in fact interested in this. So
he was just researching his mushrooms.
Right. He just wanted to roll and wondered why he was getting so much bank for it.
Yeah.
So now this gets published in Life magazine. It becomes really well known in the United States. And then unfortunately, there's this kind of sad end of the story, which is all these famous people, these beatniks, all go down to southern Mexico and take over this poor healer's village, trying to have the same experience as this guy.
Once again, some things never change, right?
Now we're going to get even shorter. We're going to just stick in ecstasy. And that one's a little easier. Gets synthesized in 1912. They were looking for a blood clotting agent. It didn't work for that. It gets shelved until about 76. So now, the work with psilocybin and LSD are getting shut down. So when this becomes available, it's not regulated. And it's starting to get used in psychotherapy a lot, especially in Northern California, like in the San Francisco area. A term that I have seen many times was a reference that it was penicillin for the soul.
I mean, again, I don't know. I mean, penicillin is good for specific infections. I don't know.
I just thought you would love the metaphor because it's so messy.
I do. It's so messy. I know. I'm trying to make sense of it. I'm trying to even make sense of what snarky thing I'm going to say about it. But you're right. It's just a mess.
The life on this one, the history on this one's kind of short because by 1985, it's already classified as dangerous. It had its brief history. Not that it's not still used, of course, but so that was in the early 80s. It's being used at raves. That's when it gets its name, ecstasy. And we can talk about its mechanism here in a little bit. All right, so now we have everything under Schedule 1. Research has been stopped. And then there's always this group of people who persist in thinking that these drugs have tremendous value. And with private funding, Johns Hopkins in 1999 starts up their program with the psilocybin. And then even earlier than that, there was a project with DMT back in 1994. And that kind of brings us back to then more current day because the research has now been replicated and increasing in frequency, both in basic science and clinical studies. And that's we talked about that earlier about the anxiety in the terminally ill patients, smoking cessation. Those were some of the early ones that got a lot of attention. So, and the reason now, by the way, that we're even talking about the psilocybin instead of LSD is back to politics is because LSD carried so much baggage from the counterculture and from the 60s. And so that one is going to play some catch up, I think, now in terms of current studies.
Mm-hmm. I mean, were you aware of these drugs when you were growing up? Did the war on drugs or specifically these messages about LSD, etc., like make it to you? Were you aware of it?
Nancy Reagan was really clear to me that I wasn't to use anything.
Right. I know that I know you had not heard of this book, but I really just want to give a shout out to any young girl in probably the early 80s or late 70s who was reading Go Ask Alice, which turned out to be a fake book, a fake diary that was presented as a true story of a girl who had LSD slipped into her Coca-Cola, which eventually led to a heroin addiction and prostitution and some other things. And that is, I think, the first time I had ever heard of LSD. And then I was it scarred me for life. Like even still, I have the images from reading that book in my mind when you talk about it now. It was a really effective piece of propaganda.
I was going to say propaganda works.
I mean, that's right.
It did what it was supposed to do, and it kept you safe, really.
Yes. We're going to go with that. Moving along.
Yeah, right. Yeah, do you want to ask you any more personal questions about your exposure and use?
I mean, right, about which drugs. I mean, there is really interesting hot stuff about the harm index of these drugs versus alcohol, marijuana, other more mainstream things. Like it's all it's all political, it's all marketing, it's all kinds of stuff. But these compounds, what are we calling them, are not really addictive or habit forming, and they don't cause the same kind of harm at all compared to most other things, including alcohol, cigarettes, marijuana.
Yeah, especially in a clinical setting. And we should have probably mentioned this with George's question, but there's a lot of really dangerous drugs that we give people all the time. I mean, the opioid epidemic is a problem, but no one is suggesting that we don't use opioids or opiates. I mean, can you imagine not having access to those? Those are really, really important drugs. If you just shattered your femur in a car wreck, I mean, my God, like I would hate again.
And like a lot of time, go ahead.
Just a lot of this is very illogical. In terms
100%.
And it's all tied up with our hangups and this history,
our Puritan culture,
right? And again, our disdain of
hippies,
the hippies, the dirty hippies. I don't know. I may take that out.
I don't know.
Yeah, it's unfortunate, but it's important to acknowledge. And I guess we've already done this, so I'm belaboring a point. But it's important to acknowledge that these things are not pure. Science is not pure. It cannot exist without a culture.
Well said.
So why don't we talk a little bit about what these drugs are doing, at least what we know, which is not very much.
Sure.
So there's the classic psychedelics. So we've talked about LSD. We've talked about psilocybin. There's DMT. We haven't talked about that, but we can in the future episode. Those are primarily serotonergic drugs,
Mm-hmm.
meaning that they interact with the same kind of neurons that serotonin does. So it's the 5-HT2A receptor,
2A.
but a lot of other sub receptors. And honestly, there's also a cascade effect that happens after that. So this is all simplified. Interestingly, though, LSD actually has an affinity for those receptors more than serotonin itself. And it might explain, too, why those experiences last even longer than the psilocybin.
Yeah.
And then MDMA is very different. It has a lot of the same properties as those others as far as the serotonergic effects, but it's also a stimulant. I mean, I rattled off the name
Dopamine.
earlier. Yeah, I did say methamphetamine, which is part of its name, and it increases oxytocin. And so there's a lot more going on with that one. But
Right. I mean, I think some people put it into a category of like empathogens, right?
right.
Oxytocin being like the love chemical. And
The cuddle hormone, I think, is the one I hate the most. But
Okay, sorry.
yeah.
Yeah, sure. You can get it from breastfeeding or club drugs.
Or staring at your dog's eyes, apparently.
Is that right? Okay,
Yeah.
no.
And the dog's oxytocin is also released.
I
So we do this thing, yeah.
I'll believe it. I just was trying to put it on a spectrum.
Yeah.
I don't,
welcome
do cats
welcome to
have that? I don't know. I only have a cat.
They have more disdain, probably not. But
That's right.
yeah, welcome to my house where we
You're just staring into the dog's eyes.
We stare at the dog's eyes
and
you say, you're trying
like,
to make my oxytocin so that I'll hug you. Or yeah, it's ridiculous. But okay.
You guys sound fun.
Hey, it's a wild party here.
Uh-huh.
Loving our dog.
Okay. All right.
Let's talk about the effects on the drug. So for those that haven't, I mean, everybody knows this stuff. I don't know. So there's distorted body image, synesthesia. So that's when a sensory experience is experienced by another sense. So you see music or you could taste colors. There's strong emotional states, euphoria, crying, a distorted sense of time. There can be illusions and or hallucinations. There's that state of increased suggestibility, which I mentioned, which is maybe why the CIA was interested in it. But the most important effect, okay, we're going to get back on task here. It appears that to get a good therapeutic benefit from it, the most important effect is that the person has a mystical or a spiritual experience. So those are correlated. And of course, if your next question is, well, what is that? That's a very good question.
It was going to be. How possibly would you measure or quantify a mystical experience?
Oh, thanks for setting that up for me. With the 30-item Mystical Experience Questionnaire. So,
what a great name.
Yeah. So, I mean, researchers have to have some way of measuring these things and hopefully comparing it to other people's experience.
And I'm glad they do. It's just, yeah.
Yeah, because it starts getting hard, right? We're talking about a transcendental moment, an epiphany. It leads to a dramatic change in a person's sense of their self and their behavior. I can read a couple of things from the MEQ30 if you'd like.
Please do. Will we put it in the show notes or on the website?
Yeah, you should read it, and that way you can know if you've had a mystical experience or not. So at least you can quantify.
Well, which again, I'm going to keep saying, people have these experiences. All that stuff, all of those things, even that you've already listed, occur in people's minds in other settings or in response to other things.
Yeah, and actually, yeah, thanks for saying that, because I am probably coming across as a jerk. I have experienced a sense of awe. I realize that's not the same as what we're talking about, but it is a component of what we're talking about.
Absolutely.
I mean, I'm not a guru.
And people have synesthesia, right? I mean, people have that as just part of their baseline experience of being in the world. Some of this is like dreams. There are different aspects, but I do think it's pretty interesting that it's producing states that occur outside of just the experience while under the influence of the compound.
Yeah. And we mentioned people who are very good at meditating can certainly have these same kind of experiences. And actually, through all of human history, there have been religious mystics. And I mean, there's...
Yeah.
Yes. These happen. They happen a lot. They've happened throughout history. And now they can happen with these particular drugs.
That's right.
So a couple from the MEQ30, a certainty of encounter with ultimate reality, in the sense of being able to know and see what is really real at some point during your experience. You are convinced now, as you look back on your experience, that in it you encountered ultimate reality. That is, that you knew and saw what was really real. Feeling that you experienced something profoundly sacred and holy. So to talk about what I think are two of the most interesting elements of the mystical experience, one is the noetic quality, and noetic being defined more by William James, which is the idea that you have now been shown absolute knowledge. Truth
Right.
has been revealed to you. Something is now intuitively true. It's where a lot of times people come out of these experiences and what they're saying is actually mundane, or it's an aphorism. I keep thinking of, like, the Beatles tell us, love is all you need.
Right.
But you can approach that with such cynicism and detached irony and all that. But if you can imagine actually experiencing that,
Believing it.
yeah, believing it, that's a completely different take.
And you could see how this would align with religion in terms of people's either religious beliefs, or if someone was in such a, I don't know, state of faith, or because some of that to me sounds like statements of faith, right? Like, I know in my soul that this is the absolute real truth.
Well, and people describe as best they can, that this actually brings me
Yeah.
to the other part of the experience, is that it's ineffable. You mentioned this early on, but that it actually can't be articulated. But in the accounts, it's that for many people, it is very much about experiencing the creator of the universe, or the experience that all consciousness is shared by everyone. There's a cosmic consciousness that they've tapped into. And so, I mean, everyone's account's a little bit different, but they all share some similarities, which is why they have that questionnaire. And again, I hope I didn't come down too hard on it, because what do you do with something that by its nature can't be described? It's really hard to study.
I've read accounts of people, like you said, feeling like it was the creator or the universe or the Holy Spirit, or right. And I'm sure that people in other parts of the world can have these experiences and then map their own language and culture onto them in an attempt to describe it. And so I think the questionnaire, probably uses words like really, really real, because that leaves enough latitude for someone to be able to put their own meaning on it or their own belief system to help describe it as best they can.
Right, which I think that is why it's therapeutic. And
Absolutely.
that's why it doesn't really matter that all the experiences are different, because it's how do you interpret it? How does it, what do you take from that you can now change?
Yeah, which goes to our point too, that I think this could be powerful with a therapist who knows you well also, to help you make sense of it, right? I mean, if life is about meaning making and you have this hugely impactful experience, okay, let's figure out what it means for you together. I mean, that is incredibly exciting to me.
So, yeah, this stuff, again, every part of this topic, there's so much to explore. In the interest, though, of moving us a little forward, let's just pivot into what we think might be happening in the brain. Like, what's some of the neuroscience behind this? This isn't sorted out. There's a lot of good debate and conversation and more research going on. But let's talk a little bit about the default mode network. So the default mode network is these interconnected regions of the brain. If we just simplify this a lot, some components of this are part of our executive functioning, the boss of our experiences. What do you pay attention to? What are you supposed to remember? How do you sequence things? It's called the default mode because when you put people in a scanner and you're not asking them to do anything, they're not tasked with something, this seems to be our setting. This is how we idle. The boss is awake and the boss is sort of running things. So when people are given tasks to do something like self-reflection or to think about how another person might be thinking or their autobiographical memory, some of these networks get even more active. In other words, the idea is that it appears.
You don't have to hedge that much. Nobody's going to hold you to this.
I'm hedging.
Yeah.
It appears that some of these regions of the brain are what create our subjective experience, how we perceive ourselves. Like, it is the I in your self-talk. It's your view out of the window of your eyes. This thing that is actually an illusion, but we think that may be where it resides. And so if you give a person a psychedelic drug, this region becomes less metabolically active. In other words, the sense of yourself, the person who seems to always be in charge and how you have defined your existence, goes away. It dissolves. You know, the dissolution of the ego, the transcendence of the ego. That constant yammering in your head finally shuts up, and you're experiencing a state of consciousness in the absence of the self.
Which is why it would be helpful in end of life to lose the sense of yourself as the main character, the most important part, to appreciate your place in the universe or being connected with the universe. That gets rid of some of that anxiety. Or I think in depression, which sometimes people get overly self-referential, right? Overly self-conscious or self-critical or whatever that is. I think disrupting that makes sense. You know, I'd also like to point out that we generally need an ego or this system to be online to live our lives, and move through the world.
I'm happy to have a working executive in my head. But when we think about conditions, like at least those conditions that, as you're saying, have more self-referential thoughts. I mean, the I'm no good, nothing can change for me. I can't live without alcohol. I can't live without a cigarette. I'll always feel this way. I'm too fat. I'm too skinny.
People would be better off without me. Right?
Yeah.
I mean,
and what I think is really cool is that this is ultimately one of the outcomes of therapy.
Right?
Of just our traditional approach.
Yeah.
And so now we can just tie this all up back to part one and say yes to George's question. It looks like this could be really profound for therapy, for accelerating the process, for deepening the process. It's really cool.
It's really cool.
Okay, so before we go, should we talk a little bit about some of the trouble with the research so that listeners, as they're getting bombarded with information, they can think about these things? Or what do you think?
Yeah, sure.
Okay. So a problem with any controlled trial, a randomized controlled trial, is that ideally the participants and the researchers don't know who has the active intervention, like who's getting what. It's really hard to blind a psychedelic. Everybody knows who's tripping and who's not.
Because again, we're right. If your executive function is off, I mean, I know definitely people are being escorted to the bathroom, right? Or they don't know who they are. Like you're not going to get that with a placebo pill, no matter how good the placebo is.
Well, and they get really disappointed because another limitation is that especially maybe not as much in the phase 3, but these are all self-selected. So these are people that they came into the trial because they wanted to have the experience, and then they get a placebo and then they're really disappointed. And by the way, these are general limitations. Each study is different, but again, these are some ideas to think about. So one is, if you've gotten a placebo, you might be disappointed this time, but many of the studies are crossover design. So in other words, if you got the placebo this time, we'll switch you and you'll get the active next time. And then that actually limits longer-term follow-up of the placebo group to see what happens. So you missed an opportunity there. There's inconsistent medication doses between studies, so you can't just compare one study to another unless you've verified that, it's an apples to apples kind of thing. There's not really a lot of definition about the therapy that's happening, and that's kind of a difficulty in any kind of therapeutic intervention. You can manualize it as best you can, and they've done it, but it's another variable that's hard to control. In the same way that it's really hard to quantify, well, what was the impact of the therapeutic process? What was going into an office and spending a couple hours with a therapist and then the integration session? I mean, there's a lot of the shamanism that is hard to put in numbers. And then also in terms of the participants, many of them had a history of having used psychedelics before. And so then that sets a new expectation, or their intention might be a bit different. In other words, their experience, because it was already defined by a past experience, you can't then generalize that to a person who has never had the experience, if that makes sense.
Right.
So, and then maybe finally, the numbers have been really small. Phase 3 trials are designed to be bigger, to enroll more people, to make sure that those statistical differences are actually clinically different. Because, sometimes numbers look one way and, reality and clinical use look very different. So,
good summary.
All right. Well, we hope you stuck in to the end here, and we hope that you enjoyed it. Hope it was helpful. We'd love to get feedback. Please tell a few other people about the show. We really do need some more questions, and you can send those by email or by an audio message at our website, callthepsychiatrist.com. You can follow us on Instagram and Facebook at Call the Psychiatrist. All right, thank you. Take care.
Bye. Oh, Dave, you got to have faith. We're all one. If we want them to be listening to the end, maybe our intention can meet with their intention. I don't know. I don't know.
Oh, you really are on mushrooms, aren't you?
I wish.